Actually, there were about 3 cases of meniscal tears which we had repaired during the procedure, and all of the other cases which had a minor meniscal tear, we did a meniscal balancing which operated during the arthroscopy. Meniscal balancing, there were 7 cases, and meniscal repair was done in 3 cases.
Do you have any preoperative value of the posterior tibial slope?
Yes, sir. We had calculated the posterior tibial slope.
Preoperative?
Yes. The average was 9.1 preoperatively, and postoperatively it was 10.4.
So that was increased.
Yeah, 1 degree of increase. None of the patients had more than 2 degrees of increase.
So why did you try to correct that during surgery?
Actually, we did a uniplanar osteotomy, so we did not do a specific correction. So we were actually trying to study if this osteotomy is going to alter the posterior tibial slope after the surgery.
Usually, the high tibial osteotomy, unless you try to correct the slope, usually there will be an increase in the slope postoperatively. That is what happens. Usually, unless you try to correct or try to reverse the slope. So unless you do that, your ACL may not survive in the long run. So one of the factors which determines the long-term survival of ACL is the slope, posterior tibial slope. So you could have corrected it, that also for operating.
The results are comparable with H2O plus ACL and isolated H2O. Then one can think about when you slight slope arches, mass instead of 997. So that also will give additional stability for an ACL.
Yes.
So do you really recommend to take an additional chance for a congenital complication if you do an ACL reconstruction also along with this?
So one of the methods that we can do is do a closing wedge osteotomy that can actually decrease the slope. But because this technique is more complicated, that we have to do a proximal fibula osteotomy as well as common peroneal nerve dissection. That is why we went out for a medial opening wedge osteotomy. And regarding the slope, from the studies, what the authors have described is more than 3 degrees of difference from the preoperative values will result in a significant increase in the stress. But in our study, only about 2 degrees were the maximum increase.
Even in the open osteotomy, you can give more open the most sliding, you can correct the slope.
Yes.
That's what recommended, especially in case of ACL recon. ACL revision is.
Yes. Or we can use an asymmetric wedge also.
Usually in the final outcome, you are able to assess the reversal of osteoarthritic changes. So what do you mean by the reversal of osteoarthritic changes? Is it a radiological or a clinical?
Based on the Kelvin Lawrence state the varus deformity, that the joint space narrowing was definitely improved after by doing a varus high tibial osteotomy, as well as in some 2 cases we had to go in for a repeat arthroscopy to look at the due to other causes, and we noted that there was fibrocartilage growth happening on the previous deficient areas of the cartilage. So that is how we acknowledged.
This is a technical question. When you plan your pseudoplate, it's a prefixed cancerous screw which goes up. Does it come on a way to your ACL track, tibial track?
So that is why in the procedure we did not put the anterior proximal cancellous screw initially. We did the tibial tunnel drilling first. After that, the putu plate have a polyaxial screw, so we can slightly manipulate the angle and avoid the tibial tunnel trajectory.
Proximal cancerous screw doesn't have a polyaxial. It's the distal part.
So proximal, and then we also used a
Did you come across the problem of facing the screw?
No, during our study we did not have any problem.
Okay, thank you.